Good evening. I'm Warren Hammert. Want to welcome everybody on behalf of AHS to our practice series webinar. We're playing the introductory slides here. But after we get through this, I'm going to turn this over to Sahi, who is our series lead for the webinars, and we will get started. So Sahi.
Thank you, Dr. Hammert. Thank you all for joining us. It looks like we have robust attendance already. Just to remind you all, this is part of our practice series webinar. This is the second webinar that we're doing in the series. The first one was about financial education for residence fellows and young attendings. And thanks to those who have attended that, that recording is available on the website for anyone that wants to join. Today's topic is an exciting one, and I'm hoping that's why that most people are here. It's a hot topic in hand surgery, and we're going to discuss office-based hand surgery, the why and the how. We have an action-packed lineup of great topics that should, get you from thinking about this in your practice to really implementing it and fine-tuning patient care as well. So without further ado, I'll turn it over to Dr. Dan Lewis from OrthoCarolina, who will be our moderator for the session. Please feel free to chime in through the chat with any questions that you have. We'll be happy to answer any questions through the chat and can direct them to the speakers as well as needed. Dr. Lewis, take it away.
Thanks, Sahi. Good evening, everybody. So this is a fantastic topic we're going to review tonight. Office-based surgery is definitely gaining a lot of momentum, particularly in the hand surgery landscape. So again, Dr. Hammert is the webinar lead. I'll be the moderator. I'm from OrthoCarolina, and then we have Sahi Dendaluri. Dr. Adams is not with us tonight, but we do have a video from her, and Asif, as well as Keith Nord, Samir, and Dr. Lalonde will be joining us as well. So we're going to move forward with Dr. Adams' first video, which will be the benefits of a procedure room.
Good evening. Thank you for inviting me to be involved in this webinar. I'm so excited to learn from all of the speakers. I am pre-recording just because I am on call, but I hope to be able to join you in person. My task is to talk about the benefits of a procedure room. And really, when we're talking about a procedure room, we're talking about doing wide-awake hand surgery in a procedure room. And the idea is that we use local anesthesia with epinephrine, so we don't need a tourniquet, we don't need an anesthesiologist, and we don't need an operating room. And the goal is to decrease cost, decrease the time, improve the patient and surgeon experience, and increase access and availability of care. And really, the opportunity is huge. You think about all the procedures that we do that could be moved to a procedure room. So you obviate the need for all of these staff, the PACU staff, the pre-op nursing, the CRNA, the MDA, all of these medications, the IV, all of the gases that might be used, and all the medications, the operating room, and all the instruments and other things that go on with that. And in many cases, you can do this quite safely because it's no different than what may be done at a dental procedure or an injection in office. So you may not need as thorough a preoperative optimization with multiple subspecialist visits because you aren't putting the patient to sleep. You may not need laps at all. You may not need any extensive workup. And people have studied how much can this increase efficiency in the OR, and found that it's the OR is half as efficient as the office, and a hospital-based carpal tunnel is 4 times as expensive. The NHS found £750,000 over the course of 1,000 patients. And so the savings can be pretty dramatic. You can also increase efficiency by creating a one-stop shop, meaning you evaluate the patient and you initiate treatment right away. And in the NHS, single case, see the patient, initiate treatment, £2,500 per case. Peter Ree has studied this in the American military population in the setting of carpal tunnel. And I think that this is a real opportunity, especially when patients have these high deductible plans and really are seeking care and trying to get in, get taken care of, and move on with their life. This is really great to educate patients. I love it for flexor tendon repairs and tendon transfers, and even for fusions, because you can set the appropriate angle, let the patient kind of participate in telling you, I can do what I need to do in this setting. This is a patient of mine who had an EPL tendon rupture, and hopefully this will play intraoperatively. You can be able to check and make sure that your tension is appropriate and that you are getting the result that you expect to get. You can adjust it as necessary. You can see intraoperatively, there's the wounds, they're open. And then you can be assured that postoperatively you have a simple reproducible result and that you and the patient are happy with what you end up with. And I think that this is a real advance for our patients. It can increase access to care in low resource environments. And the pandemic really taught us about this. You think about COVID-19 when we were totally shut out at the OR. This was a way for our patients to get care without anything that was deleterious to their pulmonary status, and also saving the OR time and staff for the bigger cases that can't go in a procedure room. If you look at the military system, improve resources, improve patient satisfaction. You look at places like Ghana and look at outpatient local anesthesia procedure rooms and finding that this is a real option. It's also a sustainability thing. So these two articles, one's a meta-analysis, or one's a review rather, and the other one talks about a lean and green surgery journey. I think they're very interesting. And you think about the cost and the cost saving translated to the number of carpal tunnel releases, for example, done in the US, you could save $450 to $560 million a year if 70% of US carpal tunnel releases were done in a procedure room. And that's just astounding to me. But you think about the waste. So I love pictures and pictures like these that show that here's the amount of waste from a procedure room versus the giant amount of waste in a operating room. And this paper by Dr. Vandermark describes his lean and green surgery journey. He visited Dawn and initiated a wide awake practice, looked at what's in the pack, pruned it, found some cost saving, then expanded it institutionally and really made a difference. And when we think about sustainability, we think about, okay, well, what's in our pack and what has to go to the medical waste, which is very expensive to dispose of and often ends up in the air we breathe when it's incinerated. But we're not really thinking about, okay, well, what does it cost to make that piece of plastic, to make that drape, to make all these light handles and get them to the operating room, process them, sterilize them, wrap them in plastic and more plastic. There's raw energy, there's extraction, there's digging it up, there's fossil fuels that are being burned to drive it to your facility. And drive it away. So I think that really we're not measuring the true impact of the sustainability of this in hand surgery. Well, what about patient satisfaction? It's higher than conventional, and 99% of patients would recommend it for themselves or their family or do it again and say it's the same or better than a dental visit. It's almost painless. And I think this is really key because you think about the amount of pain from an IV start, that's kind of annoying, and the labs, and then this and that and the other thing when you have conventional anesthesia versus a very, very small needle, and it can be nearly painless. Other speakers are going to talk about how to do it, but suffice it to say it's quite simple and easy. And I think that it's something that is easily done in the office, and therefore, why shouldn't it be done in the office? One thing that's key when you set up your procedure room is allowing enough epinephrine in the work. So the ways I've set up my procedure rooms is either having a dedicated procedure room with patients coming in at certain times. So I numb them up and then I set them up and then I do the procedure, and it's kind of a stepwise fashion. Or I have the patient come in, I numb them up, and then I go back to my clinic rooms, finish seeing a few patients, and then do the procedure. So it's very flexible. I think it's also a patient selection thing. As you get started, you pick the patient that's appropriate, that you feel comfortable with, and you can start out. Maybe you don't feel comfortable doing wide awake in a procedure room. Maybe you want to do mostly asleep local anesthesia in an operating room, and then you do mostly awake, and then you do wide awake in an operating room, and then you get to the procedure room. And I think that this can be a really, really good mechanism. There's barriers, they're legitimate barriers, but the body of literature now suggests that this is the standard of care. And so acknowledging institutional issues and patient issues, but being aware that there's a whole body of literature that suggests this is the standard of care, that it's safe, effective, it's better for the patient, the surgeon, the payer, the environment, and patients. Patient comments, thanks, that was fun. Why would anybody have anesthesia for this? You're done. That was easy. Wow, that's it. And finally, the golden rule as applies to healthcare. And what would you or your family want for themselves? And these are my elbows. I had cubital tunnel surgery. I had it under wide awake anesthesia with a magnificent surgeon who is a wonderful person and a wonderful human being. And I am so grateful that I had this as an opportunity and an option, and I would never choose anything else. So choose what you would choose for your patients, for yourself. Thank you.
Fantastic. So she's not, Dr. Adams isn't here to answer any questions, but I'm going to ask a quick question to keep us on time, and we'll see if our participants can go ahead and answer. So one of the most common questions I get as we have our own minor procedure room is, what percentage of my total cases are done in the minor procedure room? So do you mind, panel members, each of you going through and say how much of your total percentage of cases would you say are done in a procedure room?
Yeah, I can start with that. So at the end of my 40 years, because I increased more and more all the time, it was just about everything. All of our skin grafts, certainly all our Dupuytren's, all of my cubital tunnels, carpal tunnels, obviously trigger fingers and stuff. But pretty much most hand surgery you can do in a minor procedure room. I think the main thing that I didn't was implanting permanent materials. Like I wouldn't do a PIP joint silicone and with field sterility. I think with full sterility you can do implants, but for me that was the biggest no-no. But it wasn't about how sick the patient was. The sicker the patient was, the more I wanted to avoid the operating room and just do a minor procedure room with zero sedation. You can do minor procedure room in the hospital. If they're really sick, you can even do them in the clinic in the hospital, so you're closer to the emergency department, but you're never going to need the emergency department, not for surgery. The problems are not with surgery, it's with anesthesia.
I just build on what Dr. Lalonde said, but I'm about 50-50 procedure room versus ASC in terms of my cases. I treat condition of the whole arm. So as I do more shoulder and elbow stuff, it's mostly under anesthesia. A lot of my hand wrist stuff most of my hand wrist stuff, soft tissue is under local. And like Dr. Lalonde said, when it comes to implants, then that's going to go most like a distal radius or what have you. It's going to go into an anesthesia. But things like DIP fusions with headless screws, what have you, we do them all as well under in the procedure room. So the bottom line is there's a ton of flexibility in terms of and I have colleagues who all they do is triggers and mucus cysts in their procedure room, and that's fine too, because what that does is offload their other OR schedule, so they don't have to lose OR time that's valuable for smaller cases.
Yeah, I'm
I would
sure we'll
echo
touch on
that.
this.
Go
you
ahead,
know,
Dr.
I apologize. I pre-recorded because I'm on call and it's totally unreliable. But I did an ortho trauma fellowship, so all the big cases you reserve for the OR. And if you can offload yourself and get the trigger fingers, the carpal tunnels, the smaller cases, and some tendon repairs, move those to a procedure room, it really makes a difference in accessibility and OR time.
Yeah, I think the only thing I would add is, and I'm sure we'll probably get to some of this later, but choosing ahead of time if you're going to take this on and building a setup to do this of what you want to have your scope be will really help you set up a good workflow. So the more you try and do, like that's probably something that you kind of grow into as time goes on. Whereas if you're trying to just set out and be like, I want to set up a minor procedure room, it might be a wise choice to be like, let me limit the scope here and really kind of grease the wheels before expanding that.
Perfect. Yeah, so one of the other things too, you know, if you own a surgery center, one of the other things it does is it does free up some time for cases in your surgery center for larger cases where we could take cases that are, you know, as far as reimbursement to the surgery center, bring those out of the surgery center into the office. It saves patients a lot of money. It's a lot more efficient. And then larger cases, like in our center, could backfill with, you know, hip and knee replacements and shoulder procedures, a lot larger cases that are moving from the hospital. It's kind of like a waterfall cascade, if you will, as we could pull a lot of those cases out of the surgery center. So we're going to move forward. That's a segue to the next talk by Asif Ilyas. It's the financials and obtaining institutional support for the procedure room.
Okay. Thank you. So I want to thank the association for the opportunity to give this talk. It's a topic that I find very important, and I have some disclosures around it that I want to share. These are my overall disclosures. I do have one conflict. I have an equity position in a company called Wallon Surgical Solutions. I will not be talking about this company, but I will share some of the experiences related to that in support of today's discussion on financials. So again, we're covering a number of things regarding office-based hand surgery. I think this is a great set of topics for those who are looking to start this process. And I'm going to be talking specifically about financials. And I'm not going to get into the gory detail of the numbers as much as I'm going to kind of talk about strategy, mindset, approach, and tips and tricks in terms of this process, because the numbers vary a lot, but I'll throw a few numbers at you. First thing I want to emphasize is that surgery is business, and medicine is business in general. We often don't think about that. We spend most of our days rightfully focusing on medical and surgical care. But we shouldn't also fool ourselves that this is, at the end of the day, what we do is absolutely financially driven. There's many players involved in this, including ourselves. We are part of this process. We draw a salary or some income from this. Patients pay for it. Hospitals are involved with it. There's many players in this. So we have to kind of shift our approach and mindset, take our white coat out, put our suit on, and kind of think about this in a little bit of a different way. And the other thing to know is that when it comes to hand surgery, particularly office-based hand surgery, it's actually quite good business from a simple dollars and cents perspective. There are specialties and procedures and interventions in medicine that are not cost effective and makes money, but hand surgery does. And so there's a lot of room for you to create a financial dynamic that is both good for your patients and good for you and good for your practice. So I just want to establish that as kind of a starting point. I'm going to lay this out. I have about 10 minutes to talk. I'm just going to lay it out in two parts. One is just trying to, assuming this webinar series are for folks starting to focus on principles. So if you're trying to start out to establish an office-based practice, a procedure, and whatever term you want to use it, how you first get that process started. And then the second half, I'll talk about some of the financial dynamics of how you can drive insurance rates for yourself. So the first thing is you have to be able to articulate the financial benefits. You have to understand them. And Dr. Adams mentioned many of them, but I'm going to reformat them in a different way for you. But you have to be able to effectively, clearly have an elevator pitch on this and understand right away what the savings are. So there's savings to the patients right away. No pre-op workup, no EKG, no blood work, no clearances. They don't have to pay a facility fee if they're going to a procedure room. There's no anesthesia fee. There's less time off from work. One of the things we forget about as surgeons, as surgeons, and not being a patient, is that patients are running around doing all sorts of pre-op stuff before their surgeries. That takes time and money and time off from work. So they save all of these things, which is a lot. There's benefits to the system, and I use the system or center here. What I'm talking about could be your practice, could be your hospital, could be your health system, could be your employed managed care system, whatever. Having a procedure room can free up OR space in busy ORs. They would rather do high-paying procedures than low-paying procedures, right? Frees up your staff. We often underestimate the amount of time our staff is chasing all the paperwork ORs require them for patients, the clearances, the blood work, et cetera, et cetera. It's a lot of work that our staff has to do. And hand surgeons are high volume surgeons. So we'll do 10, 12, 15 cases in a day, and our staff has to chase that stuff down. So it frees them up. And there's going to be increased revenue from surgeons' fees. So if it's a system where it's not a eat what you kill, but they're collecting your revenues, they're going to do better when you do better from a collections perspective. Payer savings is arguably the biggest part of this. There's enormous savings to the payers, and we're going to talk more about this in the second half of my few minutes, is that they don't have to pay for the pre-op studies, the pre-op clearances, the facility fees, which are typically anywhere from 3 to 5 times the surgeon's fees, and then anesthesia fees. There's an enormous amount of savings. I'll give you some numbers to follow and to reference going forward. And then there's surgeons' benefits. And this is a benefit that and it's probably not the one you want to articulate primarily when you're trying to make the argument, but it's important to know. Again, your staff can be so much more efficient with these kind of cases. You're more efficient. You're not wasting time in a single room with wake-ups and turnovers and what have you. If you've got everyone has a different OR dynamic. Some folks are in main OR, some are in community hospitals, some have a lot of ASC access, some people don't. So you can often decompress your more high value OR time, where you want to put your more complex cases there and not fill them with mucus and trigger fingers, and decompress those kind of cases away. And lastly, you can make more for these cases, and we'll talk a little bit more about that. In terms of savings to the payer, it's a lot, and Dr. Adams referenced this a little bit, but I'm going to give you a little bit more detail. This is a paper we published recently looking at what is the savings that potentially can happen. And these are really underestimated savings. So these are modeled out. And if you look at the cost of doing a carpal tunnel release wide awake in the office versus HOPD, which is a hospital ambulatory center with anesthesia, and then ASC, or in ASC, the savings are 80 plus or 70 plus %. That's an enormous amount of savings that you are providing for the insurance companies. And generally, they're not even saying thank you for that. You're just doing it, and they're not even either aware of it, and they're definitely not saying thank you for that. So you have to be armed with this data to show the savings that you can provide them. So again, let's continue the argument of who establishing this in your practice, your hospital, your health system, wherever you are. The next thing is, once you start to understand what it is and can able to articulate the savings and understand those numbers a little bit, you got to find out who the deciders are, and that's challenging. In the hospital, it could be, or in the practice, it could be many people. It could be a senior partner. It could be, if you're in a hospital, it could be a service chief. It could be a department chair. It could be practice manager. It could be facility leadership. It could be the CEO of your hospital. It can be challenging sometimes to know who the deciders are. And the way to do this is to do this slowly and build consensus, okay? So find out who the deciders are and hit them one by one. You don't have to have one grand meeting one day with all of them in a room. That's a lot of pressure. It's better to build consensus slowly, talk to each of them individually, help them understand first what you're trying to do. Go slow in this process. Most of these people need numbers to make these decisions. Keep patients central to your argument, the benefits to the patient, and highlight the financial benefits to the hospital or health system or practice, and the potential savings to the payers. Do this slowly, build consensus. Once people start pause enough to see the numbers will speak for themselves. When you're talking about 70 to 80% savings, those numbers speak for themselves. When you talk about, say, I'm going to move my trigger fingers out so I can do another basal joint in the main OR, that makes more sense. They understand that if you can make that argument. So the last part of what I want to talk about is let's keep going up the ladder of establishing a wide awake practice. And now you're talking financials, right? So how does this work? And negotiating insurance rates may or may not be something that you'll be a part of. You might be in an employed setting where all you need to do is convince them to give you a procedure room, and that's the end of the conversation for you. Or you might be in a private practice where you've got a lot of control over, or you have some control over your insurance contracts. And that's where we work, and the company I reference is in this space, is trying to get through this to see improved rates. And this is a black box, and it's a black box kind of on purpose, kind of by design. They don't want to make it easy for doctors to have these discussions with insurance companies. And frankly, it's they don't really want to hear from us at all unless you have something really good to tell them. And so that's what you have to do. You have to have something good to tell them. So there's a few things here. First of all, do your homework. So if you're going to negotiate rates with an insurance company, you got to do your homework first. So identify who are your payers. Understand your current fee schedules. Pick your 3 common procedures. Maybe it's probably going to be 64721 or 29848 for most everyone for opener and endocarpal, then a few other things. Maybe a trigger, maybe something else, mucus cyst, I don't know. Get those most common ones. What are your fee schedules for those currently? Understand, number 3, understand what's your surgeon's fee versus the composite ASC rate so you can see what the burden to the payer is. For example, let's say most insurance companies pay you anywhere from $500 to $750 for a carpal tunnel release open. That's your surgeon's fee, but for an ASC rate for that with the anesthesia fees and the facility fees is in the ballpark of $3,000, give or take, of course. So there's a big opportunity for arbitrage between 750 and 3,000, and you have to understand what that is when you're making the argument. You can say, listen, you can double, I want my rates doubled at 1,500, but I'm still saving you 50% because you're right now paying $3,000. So you have to know what those numbers are, and then you have to be able to model those out. So create a model and say, listen, I do 50 carpal tunnel releases a year. I do 30 of this a year. I do 40 of this a year. This is the savings that I can potentially do. So do your homework ahead of time. Have those numbers available so you can come in informed with hard numbers because that's what they care about. Probably one of the hardest thing is, again, finding that decider. So in the insurance company side, it's really confusing. There's different terms: network managers, contract managers, surgical specialists, innovation specialists, all sorts of crazy names. And the bottom line is it's very hard sometimes to find who the decider is. And you might have to go through layers of people to get there. And it can be challenging. That's my last point on this is be persistent. It's a slow process. It's a frustrating process. It's not going to happen overnight. It takes a series of conversations. These companies don't move quickly. They need a lot of reinforcement. They need a lot of reassurance. They go back and talk internally over and over again to each other. They're always unsure of themselves. And they're not clinicians. They won't even know what you're talking about most of the time. I've had a conversation with one that I had 4 conversations before they finally understood that wide awake surgery meant no anesthesia. And they still assumed all along, despite me telling them multiple times, there's no anesthesia fees. And it finally clicked and said, there's no anesthesiologist. That means there's a 20% savings. They came to that realization on their own, even though I have been saying that over and over again. So my point is that it's often foreign to them. They're talking to you, then the next conversation might be talking to a cardiologist, the next conversation may be talking to a gastric bypass team. So they don't know what you do, and nor do they particularly care. They just care about the numbers. They're not clinicians. So it's a slow process. It can be very frustrating. Be prepared, know who the deciders are, and be persistent in the process. And the potential is significant. I'll just leave you with this. Looking at the data that we have, the potential for you from a surgeon's fee perspective to move cases from, say, an ASC to a procedure room is about a 2 to 5 times increase. Using the example of a carpal tunnel release, if you're getting 500 to 750 in an ASC, you can get 1,000 to 1,500 plus easy in an office setting when you take it step by step and make the argument, show them the numbers, model it out. They will understand and you can see a bump. And you deserve that bump because you are taking on much more responsibility. You now have overhead as well that you're responsible for. And it takes greater expertise, greater knowledge, and greater know-how to do this. And they will reward you for that, but you have to make that argument. I'll stop there. Thank you.
Thank you, Austin. That was a fantastic talk, and we're going to move on to the next talk for the sake of time. But I agree 100%. You have to be very persistent. It took us about 5 or 6 meetings, and they were completely clueless, a lot of the insurance companies, about what we were even talking about. And we were able to procure a lot of professional fee bumps for many cases. So it is worth it to spend that time. And it's worth it for your patients as well. So we're going to move on to Dr. Keith Nord. He's going to be talking to us about infrastructure, supplies, and staffing. Keith?
All right, I'll share my screen. Thank you guys for joining us tonight. Put my slides up here. All right, can everybody see the slides?
Yep.
Okay, perfect. So I'm Keith Nord. I'm an orthopedic hand surgeon in Jackson, Tennessee, and I'll be talking today about how to actually go about the logistics of setting up an office surgery suite, and about the infrastructure, the supplies, and how to staff it. A couple disclosures. I'm a paid consultant for Sonics Healthcare and NextGen Healthcare, neither of which I think is really relevant for this discussion, and we won't be discussing them. So couple things. What do you need to get started with in-office surgery? I think probably the first thing you need to look at before you dive too deep into this road is look at the legal requirements for your state, your jurisdiction, and your state medical board. Most of that information you can find actually pretty easily if you just Google in-office surgery or office-based surgery for example, state of Tennessee. And they usually will have pretty clear spelled out rules for what's allowable. Most states will allow in-office surgery, but they have different levels of what's considered a surgery or different risk categories. And that's usually based on how much anesthesia you're giving. For example, if it's just local anesthetic, a lot of times it will fall in the lowest category. And the requirements of what you have to have in your room and what you have to have there equipment-wise, emergency-wise, will all scale up based on the local legislation and the rules. So first thing you need to do is just look at the rules and find out what requirements you have to meet. You need a room. Really can be any room. You don't have to have a dedicated procedure room to do in-office surgery. I know many surgeons that have done this just in regular clinic rooms that they've kind of retrofitted to work for this, or sometimes a room that they even multi-purpose as an office room. And then when they're there, they just bring in the equipment they need to do small procedures. You need a bed that a patient can lay on. Frequently an exam table that is in an office room can work. You need an arm table, some kind of light. You need medications, sterile instruments. You need disposables like cleaning supplies, dressings, sutures, that kind of stuff. Any emergency equipment. Most states will require you to have privileges at a local hospital in case of emergencies. And you have to have some patience and willingness to work through the kinks because there will be things that you learn as you go with this, and that's just part of the process. So one of the big things is, and this was when I was starting up, I started at a new procedure room in my practice here in Tennessee with really just assistance from staff members at OrthoCarolina in Charlotte. But it's a process and there's a lot to it. So the question is, how much is it going to cost? For me, it costs a little bit under $10,000. Now that I've done it before, I'll tell you this can be done for less than $5,000. And I'll go through exactly what to do to make it so it's cheap and easy. And big parts that are, don't buy the fanciest equipment right from the get-go. Start cheap. Buy things from reliable, safe manufacturers, but don't buy the top of the line from the get-go. Start out with just the basics and then upgrade as you move on. You have to keep the costs low. Like we were talking about, surgery is a business. And so this has to be profitable and it has to make financial sense. But safety needs to be your number one concern when you're setting this up. So we talked already about first things first, legality and certification. So you need to check with your state and your local medical board. You can even call the medical board and ask them. Most insurances will pay for office-based surgery, but it's also a good idea to check with each payer and get a written confirmation, which can just be an email, as simple as emailing the rep for each insurance company and say, hey, we'd like to do procedures in the office for these codes. Is this okay? That way, if they ever try to claw back payments 3 years down the road, you have a written document that says, yes, I was allowed to do this. And then again, most state requirements depend on how much anesthetic you're using. I'll just skip through this in the sake of time. This was just saying Tennessee considers Wallant to be the lowest level risk category. So there really are no special requirements other than BLS training and reversal medications for any medications you use, and an emergency kit, mainly consisting of oxygen in case you need it, or they don't actually even require a full crash kit. Some states do require you to update your medical license, so that's also an important thing to look at. For example, in Tennessee, if you give more than just a mild oral like Valium or anxiolytic, you have to actually apply for an update to your medical license to do in-office surgery. So you want to check that as well on the medical license. This is just the Tennessee legislature, so I'll skip that. For infrastructure, again, know what rules you have to meet so you can actually figure that out. And then you get to the room. So what kind of room can you use? Again, any room. One thing people frequently ask about is the HVAC system, the AC. Some states do require a positive pressure HVAC system. Most do not. And again, this mainly depends on if you're staying on that minimum threshold of no anesthetic, just local. Frequently, you can bypass this requirement altogether, but you need to check in your area. Having a sink nearby is also useful. This is an example of what our procedure room looks like. So it's not a terribly big room. It fits one bed and just has a little area with a sink, a little autoclave in the back, and then a table as well. You can see we added an overhead light, but I actually wouldn't recommend that from the get-go. This is really what you need furniture-wise. You need some kind of bed. I would just start out with whatever exam table you have. It can just be a flat bed from the office, and I would just start there. I later upgraded to a motorized bed, and you can do that relatively affordable, but you can actually do this fairly cheaply. Like I said, under $5,000. You can use a medical bedside table. They're about $60 as opposed to buying a full operating room hand table, which can cost $600. You can get stools that are adjustable for under $150 a piece. So you can get all this equipment for not a huge amount of money or investment from either your institution or yourself personally if you're trying to do this on your own. As far as lighting goes, I would highly recommend just get a lamp for your loops. Get a headlamp. They're usually between $500 to $1,500. You can use them in the OR or you can use them in your procedure room. I later did install an overhead light, and those range from about $5,000 all the way up to $15,000. I don't think they're truly necessary to get started. I think that that's something you can upgrade if you decide this is really for you. This is the one I ended up buying, not promoting it. It's just, this is an example of what you can buy that works. It's about $5,000. But again, I would start with low cost things, just the basics, then upgrade as you go and you get proof of concept. For sterilization, so the big question is, are you going to do the sterilization of your instruments in-house or are you going to outsource it? I would highly recommend you don't do what I did, which is develop an in-house sterilization process. I would recommend outsourcing to start. It'll have substantially lower startup costs and less headache for you. The easiest way to do this is just to contact your local surgery center or hospital and just ask them and just say, hey, I've got some equipment I need sterilized on a regular basis. How much would this cost per tray? It's actually not quite as much as you would think, and it takes a lot of headache off of your shoulders. If you're going to do it in-house, you do need a staff member like a nurse or a technician that is trustworthy that can help maintain things for you. If you are going to do it in-house, it's very doable, and I'm happy to answer questions afterwards or reach out to anybody personally if they have questions, but you'll need an autoclave. These can be purchased usually for about $4,000 to $5,000. You'll need a service contract to stay compliant with the CDC guidelines. This is where you get into a lot of regulations that can quickly seem overwhelming, but it's really not if you just read through the rules. I mean, if you just stick to what's recommended, it's pretty easy to stay compliant with any guidelines that are out there. You have to keep a logbook of every time the machine is used. You have to log the required maintenance for it. You have to do testing on it at least weekly to show that it's still working properly, that you're not going to use dirty equipment for surgery. And you have to have 2 temperature indicators or sterilization indicators in every tray, just like you would see in the operating room. You have to have, and that can be as simple as indicator tape and then a little strip inside each thing. Then supplies, you're going to need medications. So you need to order lidocaine with epinephrine. You'll need some lidocaine, probably plain, bicarbonate. Most everywhere, even if it's not required, I would highly recommend that you purchase the reversal agent, which would be phentolamine. In many states, it's actually mandatory that you have the reversal agent on hand. And you can buy vials of this, and if you ever need to, you just crack it open and inject it right where you injected the epinephrine. And then I'd recommend having an O2 tank and a mask just available in the office for emergencies. You also need syringes and hypos and other things to do your injections. This is just a little cost sheet when I was going through all this and actually sourcing with all the numbers. So if anybody needs, places to order stuff from, this is what it actually ends up costing in a real world situation, now. And you can see here, a bottle of lidocaine is about $25. A case of bicarbonate is about $240. It ends up costing about $10 per patient for the injection. Granted, if you're in a bigger institution or a bigger office, you can probably get a better group rate than what I can get in a small practice in Tennessee. But this is a real world example of costs. The other thing that frequently comes up is, okay, what instruments am I going to use? You don't need to break the bank for this. Frankly, I don't think you need any more than really 10 instruments in your tray, and you could probably honestly cut this down even more. But this is the tray I started with, and I have not added any instruments to it in the past 3 years. So you need a knife, you need AdSense, you need a needle driver, a freer, some kind of retractor for doing carpal tunnels or trigger fingers. I've gone to preferring the Ragnells, Littler scissors, some kind of small suture scissor that can double in case your Littler scissors become dull. So I use straight iris scissors for that purpose. And then if the Littlers are dull, I've got a second pair built into the kit. And then your retractors, either a Heiss or Wheatlander. And then a curved hemostat can be helpful if you're doing mucus cysts or things where you want to kind of debride the bone slightly. And then you need a tray to put all this in. And you want to try to get something that's small so that these don't take up a huge amount of room. The one that we have is actually incredibly small. It's just big enough for the instruments. And I'll show you here, if anybody wants to screenshot or get these from me later, this is actually a pick list of all these instruments. And you can get this whole kit. This is not like an assembled kit. This is just me going through and searching different websites and sourcing places for how do I build a cheap instrument tray that is not garbage. And this costs about $330. So I bought 10 of these when I started because I wanted to be able to do about 8 cases in a half day. And I wanted 2 extra kits just in case. So you can see out of the $5,000 it takes to start a procedure room, you're spending about $3,000 on instruments to have all the instruments you could ever need and not worry about reprocessing things or running out of instruments mid-surgery. I would encourage you to overspend on this a little bit so you have peace of mind and you never run into a situation where you don't have what you need to finish a case. In terms of other instruments, you can always peel pack extra things, like for example, rongeurs. Rongeurs are actually shockingly expensive. They're usually about $600 to $1,000 a pop. So we just have 2 of those and they're peel packed, and if we need it, we'll go get it. A bone cutting rongeur is very useful for amputations if you're doing finger amputations. I do a lot of work comp, chewed up fingers, and those are very useful so you don't have to have a power saw system to do amputations if you're going through the bone. Needle nose vice grips are really useful. They can be sterilized if you have stubborn pins. Micro instruments, those can get very expensive. You can buy a cheap set that is not very high quality, but that meets all the requirements of the CDC. And I would just have one just in case. If you come across a nerve or something you need to repair, it's useful to have. And then extra needle drivers and Littler scissors. Disposable wise, you do need to have saline for flushing, for irrigation. I've transitioned, instead of buying bottles, I've just gone to using 10 cc saline flushes that come in a sterile peel pack. You have to be careful you don't get just the regular flush that comes not for use on a sterile field, but you can buy them for about $1 a piece. So it's not too expensive, and it just makes it easy to irrigate at the end. Blue towels, I primarily drape with blue towels. I do have hand drapes that I use for some surgeries, but the drapes are actually substantially more expensive, and there's a lot of good data out there that blue towel draping is safe. 4x4s, suture. Again, on sutures, if you're going to start out, you can buy whatever you prefer. Just from an economic standpoint, nylon and chromic tend to be the cheapest. They're usually, only a couple dollars a piece. Whereas if you buy monocryl, it's usually upwards of $20 a suture. So it can get expensive quickly. 15 blades, you can either use disposable if you want, or you can get a reusable handle. Finger tourniquets, something to do your dressings, whatever you prefer. And then one thing I've found useful is to just order a couple S-marks and they actually work as an emergency tourniquet. Say you're doing a carpal tunnel and you're having just a hard time seeing the epi's not working. You can also use a manual blood pressure cuff, just something you have, again, just so you don't end up in a situation where you feel like you don't have everything you need. Likewise, there's these little disposable cauteries that are electric you can buy. These are about $10 a piece. I think they're useful just to have. They're not as good as a bipolar, but they're useful in a pinch, where you can always tie off bleeders. That's what most of the general surgeons do. And then you need caps for surgery, hats, masks, gloves, something to clean the arms with, drapes, and something to sterilize everything afterwards, like cavi wipes. And I'd recommend getting blankets for patients as well, because they frequently will get cold, or get the shakes from epinephrine too. You want to try to keep the cost of these supplies low. You really want to try to keep it to under $50, including all your sterilization costs per surgery. And you can negotiate for increased fees like we were talking about, or secondary local reimbursement for the professional fee to help cover expenses. And you can even get that with Medicare, believe it or not. This is just a cost sheet going through the supplies, what it costs us for each surgery. And again, this is just showing like it comes down to about $44 a patient for a surgery, including sterilization costs. And then you have to worry about, okay, well, who's going to help me with this? Are you going to do everything by yourself? If you're not going to do sterilization, it is possible to do most of this yourself. And a lot of this is driven by you, the surgeon. But I would recommend, if you're going to have sterilization, you need a dedicated support person that's in charge of the room. And even if you're not doing sterilization, I think it's useful to have somebody to offload, that they check the supplies and reorder as needed. So it's not always you ordering things. Like my nurse who just runs clinic with me, she's in charge of the procedure room and she helps run all this. But I have to give her about a half day per week just to do that, so she has time to do those tasks. You frequently don't need an assistant to do these surgeries in the office, but it can be helpful, especially for holding retractors. And then staffing, just from an office standpoint, you're the surgeon, you're not a salesman. So you want to offload the money decisions to a third party, just to somebody in your office. Let somebody in your office just give an estimate of what the cost is at the ASC or the hospital or the office, and let the patient choose what's best for them. Frequently, it will be the office, because it saves them a significant amount of money. So startup costs, again, you're looking at, I think this can easily be done for a little over $5,000 if you're going to outsource your sterilization, and still under $10,000 if you want to do all the sterilizing yourself. This is my exact cost to start it up from scratch, was just under 10 grand. And you made that money back, honestly, within the first month. So it was not a huge ordeal. And then later upgrades, I bought a motorized table and an overhead light. And that's my total cost so far over 3 years. So final product, and if anybody has any questions, or I know this is a lot we just blew through, but if you have other questions about the logistics of how to actually make this a reality, I'm happy to talk to anybody or shoot me an email, or I can give my phone number on the chat if somebody wants to ask questions.
Thanks, Keith. This was a definite, unbelievably concise and comprehensive resource. So this is going to be recorded and should be available on the AAHS website. So make sure you run through Dr. Nord's slides once again, because this is tremendous, particularly if you're thinking about starting your minor procedure room. So for the sake of time, we're going to move to Dr. Samir Puri for workflow and efficiency.
Great, thanks everybody, the association, for inviting me to present. I'm going to share my screen here. So I'm going to jump right in. We're going to talk about office-based hand surgery workflow and efficiency. So we've heard, about some of the upsides for patients and doctors, how to get buy-in from your institution or from payers, how to start setting up the office. That talk from Dr. Nord is probably the best resource you could probably get in that sort of thing to really get a detailed look at actually how to do it. But we're going to dive in now to some of the day of workflows that can help keep you as efficient as possible to make this a good experience for both you and the patient. Now, the reality is these solutions are usually local. Every place is a little bit different. No place is exactly alike. So there's not a set plan that I could give you that's going to work for everybody. But what I thought I would do is sort of focus on the components that you should identify in your particular scenario so you can work through them, as each one of these steps is a potential bottleneck that you can improve. Some of these steps have to follow each other, but sometimes you can think about moving these steps in parallel to get things working concurrently to speed things up. I'd also like you to kind of reframe your concept of efficiency away from speed and more towards reliability, reproducibility, and optimizing the patient experience. If you can get to the point where you're not wasting a lot of effort, the day feels better, you're going to be more attentive to your patients even on busy days, and the patients will feel that. Sometimes we tend to think of efficiency as moving fast and getting more done, but that can lead to kind of an increased anxiety in the air, which I think affects you, your team, your patients, everybody in the room. We've all been in rooms where people are rushing for the sake of getting more and more done. And sometimes one of the appeals of office-based surgery is, well, I can get a lot done. I can get more cases done, and that's definitely true. But it doesn't always feel like a great scenario. And when patients are awake and they can feel that rush, it's much better to model for them a sense of calm. So I would say if you can make your workflows, as opposed to fast, more reliable, reproducible, and minimize your wasted effort, everybody's going to benefit from that. So to me, a lot of this comes down to how much work can I do ahead of time before I even get there. So making a busy day easy and fun comes down to that. I don't want to do a lot of busy work if I can avoid it. So I like to strive to show up and everything is kind of mise en place. It's all set up before me and I can get as much stuff done ahead of time as much as possible. So, we have our back office making sure there's no insurance issues and the patient's not going to have a bad experience with that, as Dr. Nord mentioned about, needing a money person. That seems to get harder every year, but we try and get ahead of all those issues as much as possible so that those aren't questions on the day of surgery that can get, uncomfortable or just make the experience less about the medicine and more about the billing, which is not what patients want, even if it's the reality of things. The day of surgery is not a day for indications. Hopefully that's happening back in the office. So ideally, if you are going to do a history and physical in this situation, which you may not have to do, that's just a paper that you have to sign. Consent is obviously a really large topic for surgery, and it's kind of outside the scope of this talk, but I think it is important to have a consent process, that you want to optimize. Suffice it to say that surgical consent is about a conversation, not about signing a form. So that should happen in a lot more detail in the office prior to the day of surgery. And so when our patients come, they have pre-printed consent forms that are auto-populated with whatever they're planned to do that day. Sometimes some of my partners even have those signed before the patient even gets there by themselves, and they can be signed by the patient and witnessed. Personally, I like to still have that conversation again on the day of the surgery when I mark the patient and talk to them as an opportunity for them to ask questions and again kind of get ahead of any issues later on that can kind of slow the day down. If I can do that up front, it seems to work better for me. Prescriptions became a big thing in terms of bottlenecks for us. We send all of our prescriptions prior to the day of surgery. Usually you have to tell the pharmacy when you want them released, so we'll release them the day prior because some patients like to pick them up ahead of time. But we found we were getting a lot of requests on the day up to change meds, change pharmacies, do things like that. It makes for a lot of delays, makes for a lot of redundant work. A lot of people tracking things down that should be doing other work. And so this is a sheet that my PA made, and we give it to all my patients that we book for surgery before they leave my office. And it kind of loosely screens for some medical issues that might raise a need for clearances, which is more of an issue for an operating room. But it also goes into details about questions of where they want their scripts sent. What, if any, preferences they have with regards to pain management, and we start to screen a little bit for things like pain contracts if those have become increasingly prevalent as the years go by. The anesthesia piece is a big part of the workflow and efficiency. So there's probably a lot of options, but the main thing is you should know your preferred med. And I think Dr. Lalonde's about to teach us all about this, but I would just add that whatever med choice you use gives you different options. And so I use Lido and Epi with bicarb for most patients, and it'll kick in for numbness usually within about 3 minutes in a digital block, and usually it'll last more than 2 hours. So for me, this profile lets me, can send people, mark people, and anesthetize them at one touch point before we even go to the procedure room, ideally, so that can speed things up. You may need to plan for more time for the epi to work. I would just say that you don't have to do no tourniquet. We do a lot of local surgery with a tourniquet on at the forearm level for under 5 minutes. My carpal tunnel tourniquet times for endoscopics are usually 1 to 3 minutes. It's not that bad. It's pretty benign. And so, certainly trigger fingers, things like that. At the Indiana Hand Center for a long, long time, people have been doing awake surgery with short period tourniquets with great results. And so that's an option for you as well if that works, if that helps your workflow. And so if you have the time, the room to do it, depending on what your room setup is like, you may want to think about doing these things ahead of time versus in the room while you're prepping and draping if you're going to use a tourniquet. The procedure considerations are definitely a factor, but I would say that operating faster is not really what helps you the most here. There's probably a lot more gains to be made in the infrastructure and supply chain side of things. Probably the least amount of is to be gained by operating fast. Usually if I'm trying to go fast, it slows me down, and it may not be as comforting to awake patients to see people kind of feeling like rushed. So smooth, steady, rehearse, standardize is, I think, a much better approach. And if you're doing your carpal tunnels in 7 minutes or 2 minutes, it's probably not changing your day a whole lot, given all the other things that have to happen in the case per patient, whether it's consenting, prepping, turning over the room, setting up the next case, checking in, discharging patients. These all take a lot longer and have a lot more steps than doing a trigger finger release. So there are gains to be made for sure when it comes to like the steps of your procedure, and you want to optimize that for sure. But I think probably the infrastructure, supply, staffing is a bigger factor. How many sets do you have ready to go? Do you define your scope of practice clearly so you can have procedure-specific sets potentially? That might speed things up even more. For example, when I do an endoscopic carpal tunnel, I need a pair of Adsons, a curved arrow scissor, a hemostat, and a needle driver every time. Those are the only instruments I ever really use. And so that's a really, really small pack for a carpal tunnel, and that makes it faster to set up, faster to get rid of from the room. And then to Dr. Nord's point about processing and sterilization, are people taking these equipment out of the room to be processed and sterilized after each procedure? Is it happening at the end of the day? What is that workflow like is something that you have to figure out to really make your in-between time from one case to the next go down. I'm usually not much of a believer about disposable things. In most of the situations where I've been, it's not been cost effective to do that, but there's definitely a case to be made in an office-based setting that there may be some disposable kits you can use for things to help save some of that setup time, takedown time, sterilization time that may be an option, or maybe even as a backup option. Finally, getting people out the door is always a big factor, and so we do all of our discharge paperwork ahead of time before the day of surgery. Usually, it's filled out by a combination of my MA and my PA, and then they give me a folder with a packet for all of these for each patient, either on the day of surgery or they drop it off at the office for me with the nurses who are doing check-in or check-out. And usually, we'll have our nursing team go over the discharge instructions before the procedure, before I've even seen them, so that any issues that arise or any questions that arise are kind of ready to go. So we're not kind of backtracking and trying to figure out all those answers to questions that they have when we're trying to sort of move on to the next patient encounter. So our intake form or our discharge forms are pretty standard. They have things like dressing and wound care instructions, what medications were sent, the date that the script was sent, because sometimes pharmacies will not find a medication that was pre-prescribed from several days prior in their system unless they look back to the day that it was sent. So we added that in. What's their next appointment? Our patients get therapy appointments and follow-up appointments with either me or my PA, and so those are all written down there. The prescription that the script was sent to, those things are all kind of on the paper. So we're just the whole name of the game is trying to anticipate any sort of questions people might have, getting it all down there so it's all delivered to them and they feel a sense of confidence and calm about kind of the experience and not having a lot of questions as they go. It's just another example of trying to do as much as possible ahead of time if I can. Managing your rooms is going to be a big bottleneck, and it kind of depends if you have one room, multiple rooms. You might decide if you're going to stagger patients between two rooms. You might decide to see people one at a time or in groups. But rooms need to be cleaned. Contaminated instruments need to be set aside or sent for processing. The trash needs to be taken out. The next case needs to be set up. So I try to do as much as possible with the patient outside the room when I only have one room, so that I can have my team in the back doing all these things for me as we go. And as I'm talking to them, still giving that patient face-to-face time and a good interactive experience where they don't feel like they're being rushed through. We do have one setup at our offices where we have two rooms, and in that one, sometimes we'll bring back two people at a time or staggered just slightly off by a few minutes, and then kind of do them in little batches in that way. And that seems to work pretty well for us. But again, each situation is really unique. And so looking at your own situation to figure out what is going to be the best workflow is going to be a really effective approach. The final step is to make sure that your billing and documentation don't suffer due to the amount of all these logistics that are required to keep the day moving. Most of our office-based surgeries can be templated in terms of these small minor procedures, not all of them, but I would consider a modular approach. That's worked well for me. I don't have a phrase for a whole op note when I do a carpal tunnel. I have a template just for the procedure portion. That way I can kind of like dictate the setup, and then I may say, okay, insert the carpal tunnel macro, insert the trigger finger macro right index, trigger finger macro right middle, and you can kind of just sort of put those things in there, and it seems to work well because sometimes it's not as simple as one surgery per patient, of course, with these small procedures. So, to finally, the take-home message here, I would say, is that it's useful to sort of look at each step of the patient experience when they come to the office for a procedure, because each of those steps is a potential bottleneck, but it's also a potential step that you can optimize and get things done ahead of time to make your day a lot better. Optimizing each one of these adds up, and not only in terms of time, but also in terms of your experience and the patient's experience. So it's good to define clear roles for your team and have like appoint people for the different tasks that have to get done. And I would also encourage you to get frequent feedback from those people. A lot of my discharge processes, the pre-surgery sheets I use, all that sort of stuff was not my idea. These ideas came from my PAs and my MA, from my PA and my MAs who were trying to kind of scrambling to solve these problems over and over again. They said, hey, what if we did this? What if we did that? Next thing I know, my day's getting a lot better because they're just handing me a folder with all my paperwork and it's all done, and it's been pretty great. And that's definitely a work in progress. So you should try and get as much of the not surgery done prior to the patient arriving as much as possible. And if you can minimize the work, anticipate these problems, streamline these steps, you'll be able to set up these things that'll add a lot of value for you, but also very much for the patients as well.
Thank you, Samir. We're going to move on to Dr. Lalonde, the pioneer. Go ahead, take it away, Don.
Yeah, thank you. Just going to share my screen here. And okay, you guys can see that? So there's a lot of information on this. WALANT is actually a word on PubMed now, and if I just looked it up, if you look up the two words WALANT and Office, there's 23 papers in the last 8 years, so there's plenty of information out there. There's over 420 papers on WALANT in PubMed in the last 10 years, so there's a lot of information out there. So I'm going to be talking about patient comfort. I really think that we can make our carpal tunnels a pleasant experience to be enjoyed. Instead of an operation which is traditionally endured, it can actually be fun. When I give people a guided tour of their inside of their hand, which a lot of people love, and I'll often say, "Do you want a guided tour?" So, "Oh yeah, I'd love that, man." And "Can I take a picture?" "Yeah, you can." And a lot of them leave going, "Man, people should put that on their bucket list." I think our goal should be to have all our patients leave with a smile and with their hand above their heart. I've seen a lot of Wallant videos, people walking out with their hand dangling down by their side. That's just not a good idea. And I think, you got to treat your patient like you would treat a guest in your home. You wouldn't have other people in your home treat your guest like crap. You wouldn't treat your guest like crap. You treat them like you'd want to be treated yourself. So that when they feel like a somebody, like include them in the conversations. Don't pretend that like the days of when they were asleep and you're just a technician is kind of different. You have to have a Wallant bedside manner. Because patients are going to choose you because of what their friends say about you. You want your patients to hear things like, he didn't hurt me at all. And he was so nice to me during the surgery. And, he told me everything I needed to know, so I didn't have any trouble after. And his receptionist and his nurses were great. And you know what? When I called his office, a human actually answered the phone. Like in my office, my secretary answers the phone. It's amazing how people just love that. And it's not that hard. Just get her to not be buffing her nails and not put it on voicemail all the time. The 3 A's of being a good surgeon, in their order of importance, is number one, availability. If you're not available, doesn't matter how nice you are, doesn't matter how good you are, you're not worth crap. If they can't get a hold of you, you're not worth anything to them. And so you have to figure out how to be available, even if it's just online for questions. I don't mind at all letting patients message me because I'm nice to them during the surgery. They're nice to me. They almost never bother me. And in the last years, most of them had my cell phone because I knew they weren't going to bother me because, they have respect. If you want your patient to be comfortable, don't get them naked, okay? Like nobody really cares about being naked in a in a place you don't know. So, and there's no increase in infection by having people walk in their own street clothes. There's tons of evidence about that. So, and it's just a waste of money to get them a gown and all that stuff. So don't do that kind of foolishness. And you really want to avoid unnecessary monitoring. That stuff's not comfortable listening to beeping sounds, and you really don't want to do unnecessary IV insertion and unnecessary sedation. Nausea and vomiting is really uncomfortable. And a lot of people do that when they get even sometimes mild sedation. So just pass on that. Inject them lying down. The one thing I would say about a stretcher is I think you should get a stretcher that does Trendelenburg because at least 2 or 3% of your patients are going to faint even when they're laying down. So you got to be able to get their head down when they faint. And Trendelenburg is good. Fainting is a very uncomfortable experience, and you want to avoid that by never injecting them sitting up, even semi-sitting. They're going to faint less. Fainting happens because there's not enough blood to the brain, okay? So you avoid it by injecting them flat And you help them get over it by getting their head down with Trendelenburg and getting their knees up and their hips flexed. Take a picture of this QR code. It'll take you to a video that I made on how to not hurt people, and it's got all the details, but I'm going to give you the 3 most important things here just now, but there's a little more to it than that. And this is one of my favorite things. I like to start each case with a 3cc syringe and a 1/2" 30 gauge needle. Why? Because I want to save my basal joints. They're pretty good, by the way, after 40 years of local. A 3cc syringe is not hard on your thumb, and a 1/2" 30 gauge needle is less hard on your thumb than a 1". And also with a 1/2" 30 gauge needle, you can see the needle going in and out, and you don't want it to go in and out. You never want your needle to go into a place that's live and not numb, and this allows me to make sure that doesn't happen. And here you're seeing me pinch the skin into the needle instead of pushing the needle into the skin. And I hold that pinch. And if you do that, the sensory noise of the pinch and the holding the pinch until the skin is numb, which takes usually 30 to 60 seconds. So just keep that pinch on there. The movement, the pinch, it's sensory noise that they almost don't feel the needle go in. And also I get them to take a deep breath and do it in mid-inspiration, so they're focused on their breathing. And then once your needle is in there, you got to hold that syringe perfectly still. You know, imitate the mosquito. They're wonderful at not moving at all. And that's what you want to be. You know, you want to be like a mosquito, and you can't do that if you're a one-handed wobbler. You want to be a two-handed stabilizer. Look at the mosquito. He's got 4-point stabilization, and that's what you should have too. So that you don't move at all until the skin is numb, because they feel every little wobble. So after you're not moving at all and you got this stable point, you inject always 3 cc's before moving the needle at all, ever. You know, people are so in a hurry to move that frickin' needle. Just don't. Just always put in 3 cc's before you move the needle at all. And then when you take it out and reinsert it, always reinsert it in a place that's numb. Now, this position with the hands up, you know, like when you're a kid in school and you put your hand up, that's a very comfortable position for a lot of patients. And it's a very easy way to get at the nerve. It's way easier to get at the cubital tunnel than when the arm is out at 90 degrees and you're trying to peek behind the medial epicondyle. And so when you're moving your cubital tunnels in your office with field sterility, which I highly recommend, this is a good position for many. And so the patient on the right is very comfortable with this position. I always ask them first, are you comfortable like this? And if they can tolerate getting all the local in, and they're very comfortable getting the local in, which takes, you know, about 5 minutes, then they'll be comfortable for the surgery, which is going to take, for me to do a cubital tunnel, I'm not all that fast a surgeon. It's going to take me 15, 20 minutes. And so she was comfortable, you know, no problem. She's a younger person. But this next patient who's on the left, now he was really uncomfortable with his arm out at 90 degrees. He was very comfortable with his head above his shoulder. And by the way, that's always buried dermal sutures. You shouldn't do transcutaneous. You got to take those things out. But anyway, watch this guy's face. See, he's comfortable right now. Oh no, my arm's good like that, doc, no problem. You know where I can't put it? I can't put it at 90 degrees. Watch his face. Oh man. Oh, thank you. Boy, I hate that position. Never operate on a patient who's uncomfortable. I always ask them what position is the most comfortable for them. Because, you know, you can do cubital tunnels on their side, both sides, in fact. You can do cubital tunnels on their belly and their carpal tunnel on their belly. Just ask them if they sleep on their belly. It's really easy with Walnut. You just never thought of doing it. And, you know, the visibility is totally awesome on their belly. So if their shoulder's sore and they want to keep it adducted, you can do that. That's okay. It's not a problem. And another thing is, we're so used to operating on people who are comatose that they lay still for the whole time we're there. Well, patients don't have to lay still when they're awake. They can move around from side to side. And if they got a sore shoulder, you can say, look, bud, you want to move during the case, you want to get on your side, no problem. We can do that. Just warn me, okay? I just don't want you to move while I'm doing something like, I don't know, you know what I'm saying? So patients get it. And, but don't feel married to a position, okay? This is not general anesthesia. And make sure that they're comfortable. If they're comfortable in the position to inject the local, they're usually comfortable for the whole time during the surgery. And please don't be a surgeon who says, the tourniquet doesn't bother my patients. It's only for 5 minutes. I think anybody who ever says that should at least put a tourniquet on their own forearm for 5 minutes because it does hurt. And it's really not necessary at all. The biggest problem is that we got this mindset from general anesthesia and working in the operating room of doing one case at a time. You process one patient at a time. You inject them, you operate on him, he goes out, you bring in the next one. You got to get out of this mindset. Get into the mindset of your dentist. Your dentist never does that. Your dentist injects 3 patients and then he goes and does the first one so that the local anesthesia has at least half an hour to work. And that's all you need to do. You just change the way you process the patients. Don't process one at a time. You process 3 at a time. So you inject the first 3 patients and do the paperwork and all that. While you're injecting the third one, your nurse is bringing the first one in the room. And by the time you operate on the first one, it's got 30 minutes for the epinephrine to work. So you don't need the tourniquet. And if it bleeds just a little bit when you're doing a carpal tunnel, just get your nurse to put on a pair of gloves and pull on the Sen retractor firmly. And that'll stop any little bleeders that you got in there. And even for endoscopic, it works just fine. So just get out of the mindset of doing one patient at a time. So you need 2 rooms. You need like an injection room and you need a procedure room. And any room will do for any of these things. You don't need special ventilation. There's no evidence for HVAC for decreasing infections for carpal tunnels or minor procedure rooms. The only evidence for air exchange is big hips and knees. You don't want to do paraplegics laying down, and you don't want to do this fellow on the left laying down. He's a little on the heavy side. He's got COPD. He doesn't sleep laying flat. Hell, I'm not going to make him lay flat to operate on him, and I don't mind if he's up. So we operate on him sitting up, not a problem. And the guy on the right, that guy had metastatic lung cancer. He died 6 months later, and we knew he was going to. When we operated on him. And the reason I operated on him is because he couldn't sleep at night because of carpal tunnel pain. But, he walks around with oxygen. And so I say, well, you can have your oxygen. You can stay sitting up. Are you comfortable like that? Oh, yeah, doc, I'm not at all. He actually had a good time watching the surgery. And his daughter wrote me a letter 6 months after he died saying, gee, thanks for letting my dad sleep for the last 6 months. He was just so grateful, and so was I. And I like to ask patients, everybody during the surgery, so what do you normally take for pain? Like if you got a headache or something, Advil, Tylenol, nothing? And most people say Advil or Tylenol. I say, oh, you know what? That's all you're going to need. You're not going to need any more than that. Especially if you keep your hand up higher than your heart. That's the key thing. You walk around with your hand dangling down, man, it's going to hurt, man. But if you keep it up higher than your heart for 2 or 3 days till it doesn't hurt at all to put it down, you're probably not even going to need anything for pain. Possibly just a little Advil or Tylenol tonight. But if you keep it up, you'll be surprised how many people don't need anything after the first day. And the key is up and quiet. And in the wintertime here in Canada, when patients leave my procedure room, I personally zip their coat up or get the nurse to zip their coat up with their operated hand inside the coat so that they can't put on their seatbelt. And you got to get them into this mindset of hand up higher than your heart. And that's the most important thing you're going to do for pain control, is to get it through their head that they got to keep their hand up. It's also going to cut out your hematoma rate. You almost never get hematomas when you do that. And if you're still using full sterility for either your cubital tunnels or carpal tunnels, please stop. I mean, there are so many papers showing there's no difference in infection now. And you know what we do there with just towels and so on, we've shown that the infection rate's the same as the main operating room time and time again. So I'll stop there and take any questions if there are any. I'll stop sharing.
That's great. Thanks, Dr. Lalonde, and thank you to Dr. Lewis and all of our speakers for an awesome webinar. Thanks to those that tuned in. We had over 50 participants the whole time. Thank you for staying a little bit later. Sorry we ran behind. If there are questions, feel free to email those in the chat. The email addresses are listed there. In the interest of time, we're just going to wrap up the webinar here. As a reminder, we have a webinar coming up next month on September 16th. It's going to be about advances in peripheral nerve repair. We'd love for you to join. And as a reminder to the participants and attendees, this will be recorded and the webinar will be available for review to watch later on the AHS website in the coming week or two. Thanks again to everyone. Hope everyone has a great evening.